Let's go ahead and introduce our speaker for today. It's Dr. Lucas Hill. He's currently the lead pharmacist at the Owen Clinic. He completed his PharmD at USC and then his residency at UC San Diego in 2012, coming to UCSD for residency specifically to work and train with Craig Ballard, who was our prior head pharmacist at the Owen Clinic. After his residency, he led his clinical pharmacy services for the hepatitis C mono-infection clinics here at UCSD, and then also assisted with the HIV Hep C co-infection clinic until 2017, when he joined the pharmacy team at Owen Clinic. Lucas is invaluable, as well as all the rest of our pharmacists here at Owen Clinic. And he's going to be talking today about injectable ART with lenacapavir in those unable to adhere to oral antiretroviral therapy. So, Lucas, you take it away.
Thanks, Dan. Uh, Happy 2026, everybody. First high rounds of 2026, not intentionally, but since Monica wasn't able to do last week, I guess I get the opportunity to do it to start the new year. So let me minimize this. So, like Dan had said, the focus today is really to talk about strategies for using, fully injectable regimens in people who are detectable because they just aren't able to adhere to oral antiretrovirals. And so I'll talk about one, just kind of what data is available in working with people in this situation, and kind of what the guidelines talk about, but then also, kind of the slightly different approach that we've taken at Owen Clinic in a handful of people, and talk about what those outcomes are, and kind of the rationale behind that approach. And then if there's time at the end, go over just what might be, or some of the things that are kind of in the pipeline that are coming, that might be options for people in this situation in the relatively near future. And, interestingly, up until a couple weeks ago, I actually was planning to do a different topic. And then Jill had reached out because she was in contact with someone from the CDC and Stephen Rawlings about this HIV outbreak that's been going on in Maine for the last couple of years, which it's kind of been under the radar for the most part. I don't, it's not been talked about very much, at least in national media, and apparently also not getting a ton of support. From the CDC either, but they had reached out because they're looking at injectable options for people to help control the outbreak, and so they were looking for protocols in from clinics using injectables in people who have detectable viral loads. So they reached out to UCSF and then also to us and asked for a protocol. So we send them something, and I just was going to touch on this outbreak that kind of led to the discussion. And this is it's just some of the headlines from more of the local news in Maine. Early December, they were reporting on the 31st case as part of the outbreak. And also discussions around how this is expected to, extend beyond Bangor, Maine, which is where it's happening, to, probably other cities in Maine as people move around. And so the outbreak started in 2023, late 2023, and per the reporting, what is kind of being identified as what's driving this outbreak is a few things. One is that there was a large syringe service program in the area, and there was some mismanagement as well as underfunding, and that led to a shortage of syringes, and also eventually closure of the syringe service program. Also, a lack of medical providers that are in the area that have experience caring for people with HIV. And then in the middle of the outbreak in early 2025, they cleared a homeless encampment in the area. And that was where a lot of people that had HIV as part of this outbreak were getting their care. So when they dispersed, they lost, touch with a lot of these people, and that also is leading to new infections. And so this is just from the maine.gov website about the outbreak. And as of the end of last year, they've actually had 33 confirmed cases, and they, state that this is in an area where on average they have two new diagnoses per year, including one in people who inject drugs. Kind of the demographics of the outbreak. It's really almost exclusively in people who are injecting drugs, and the overwhelming majority are also unhoused. And almost everybody also has Hep C co-infection, as you would, expect to see in people who are injecting. And so, as of the end of last year, only 57% of the cases identified were virally suppressed. And this is just the breakdown of the number of cases new cases they've seen per month. And so, anyways, they're looking at all options to help control this, and injectables is one of those. And so, when we started talking about it, Jill suggested this would be a good topic for high rounds, which I agree. I think it would be nice to have an update on kind of what we've been doing at Owen Clinic and what we've been seeing. So, just to put into context, kind of a patient case that fits kind of this demographic of people. This is a patient of ours at the clinic. AT is a 39-year-old male who was diagnosed with HIV in 2011. Benign medical history outside of chronic Hep C. I think he was treated once, reinfected, and currently untreated. Um, and he has had, long-standing non-adherence to antiretrovirals, oral antiretrovirals, and it's primarily due to methamphetamine use, but also, he just reports forgetting, struggling to refill his medications on time at the pharmacy, not always having medications with him. And we've made lots of attempts over many years to support his adherence without much success. His treatment history, pretty straightforward. He started treatment in 2011 and had been on, boosted protease inhibitor regimens till September of 2018 when he was switched to BF TAF, and continued on that through March of 2023 when he was being evaluated for injectables. Yeah, in terms of his adherence to clinic appointments, he's definitely had periods where he's disappeared for periods of time, but in the past year prior to looking at injectables, he had been showing up to essentially all of his appointments, so didn't have any no-shows. Recently, he's immune to Hep B due to vaccination. And in terms of prior resistance testing, he had one RNA genotype in 2018, also one proviral DNA resistance test in February of 2023, and both showed only an M184V mutation. And so he is expected to have full activity for NRTIs and integrase inhibitors as well. And then these are just his viral load trend from 2017 till March of 2023. So limited periods, almost no extended periods of viral suppression. Most recent viral load was 194,000. And you can see he's had, progressing CD4 decline over time, and has been less than 200 for the last couple of years at this point. So just keeping him in mind as we go through, treatment strategies, and then we'll come back to the case and see how he did. So in terms of, what do the DHHS guidelines recommend for people who are unable to achieve viral suppression, secondary to adherence, and strategies that can be used. And then, this is also, highlighting these strategies are in people who don't have resistance to cabotegravir or rilpivirine, and that's a different scenario that I'm not really gonna, cover today, but Really what we're looking at is people who are susceptible to both cabotegravir and rilpivirine. And the guidelines kind of highlight two different approaches. One is try and use intense adherent support to achieve suppression on oral therapy. And then if they can maintain suppression for a few months, then switch to cabotegravir rilpivirine by itself. And that really follows the latitude study approach. That's the strategy that was used, and we'll just briefly touch on the latitude study in a second. Um, so that's one strategy. The second would be, if you attempt intensive adherence support, and what that intensive adherence support means is a bit nebulous. There's not we all know that there's various strategies we try, but a lot of times it's despite what we attempt to support adherence, the patients still struggle. But they point out that if they're unable to achieve suppression, that you can still give just cabotegravir rilpivirine in people who are viremic. And that follows kind of the data that we have from Ward 86 in San Francisco, and also the opera cohort as the kind of the two biggest groups. There's other, published case reports and things like that, but those are the largest cohorts regarding using that approach. So, just touching on the latitude study, right? This was a study designed for people who are, or have a recent history of not being able to effectively take daily oral antiretrovirals. And they had the patients take oral ART for up to 24 weeks with mostly economic incentives to help support oral adherence, along with obviously being enrolled in a clinical trial. And if they were able to get suppressed less than 200 at 24 weeks, they were randomized to then, go on and receive either injectable cabrolpivirine or stay on or standard of care oral antiretrovirals. And the primary endpoint was regimen failure, and that consisted of either confirmed virologic failure or discontinuation during the randomization phase. And so, although it didn't meet superiority in terms of the combined primary outcome, when they looked at secondary outcomes, so both with virologic failure and also treatment discontinuations due to side effects, cabotegravir rilpivirine injectable strategy was found to be superior to continuing oral ART. And so the study was stopped early because of the superior efficacy of cabrolpivirine. And so that's the one approach. The other approach is to, just give cabrolpivirine in people who are viremic. And I think most of that the majority of the data comes from Ward 86. And they published a retrospective cohort of people who started cabrolpivirine with viral loads of greater than 50. And they define their primary outcome as viral suppression, less than 50 copies, with maintaining on cabrolpivirine through 48 weeks. And they define virologic failure as less than a 2 log decline in viral load at week 4, or a viral load of greater than 200 after initially suppressing and evidence of resistance to cabrolpivirine. And so they had 59 people that they reported outcomes on. 50% had CD4 counts less than 200. 50% were unhoused or unstable housing, about 2/3 with active methamphetamine use. And they achieved 80% viral suppression with persistence at 48 weeks, which, is obviously a good outcome in difficult to treat population of patients. And in terms of looking at true virologic failures, there were five, which constitutes a 8.5% virologic failure rate. Um, and they also had one loss to follow up. And of those five that failed, three had confirmed rilpivirine resistance, two had both rilpivirine and cabotegravir resistance. And so, again, you're still achieving, in terms of viral suppression, greater than 90%. But Obviously, this is a much higher, not much, but a higher failure rate than, what we typically see with, the 1% that we kind of quote for people who are switching to cabrolpivirine who are undetectable on oral ART, kind of meeting the package insert indication for using cabrolpivirine. So, definitely higher rates of virologic failure, as would be expected given the patient population. Some things to point out about their strategy. They did use every 4-week dosing for the injections initially, and then if patients were suppressed for 3 to 6 months, they had the option of then switching to every 8 weeks. So that's typically a little different than what most, I think, clinics are doing, which, overwhelmingly everyone, mostly everyone's using every 8-week dosing. They did have some economic incentives. They had $10 grocery vouchers for on-time injections. And then there were patients who were also enrolled in their pop-up low barrier program that was for people who are unhoused, that had additional incentives available, as well as opportunities to even go out and give injections to people in locations outside the clinic if they didn't show up. So some of that stuff may not be able to be replicated everywhere. The other cohort where we have, data in using cabrolpivirine in people with detectable viral loads is the opera cohort, which you probably know is data from many different clinics that include thousands of people who have received injectable cabrolpivirine. And they looked at a subset of people who had either a viral load of greater than 50 when they started, so 229 in that group, or a viral load of greater than 200, 93 in that group, and they looked at a primary outcome of treatment discontinuation and confirmed virologic failure. And they defined virologic failure as having 2 consecutive viral loads over 200 or 1 viral load over 200 followed by treatment discontinuation. And again, just keep in mind, Opera, the data is not quite as granular because this is, there's data coming from like claims data and things like that because it's a much larger cohort. But the median viral load was 2 log, median CD4 count was 579. So probably a little bit different than, say, the Ward 86 group. In terms of, monthly versus every 2 month injections, about a third were receiving monthly injections and 2/3 every 2 month injections. And it was a relatively short follow-up that was published for the opera cohort data. Median follow-up was 6 months in those that had a viral load of over 50 and 8 months in those that had a viral load over 200. And 80% of the cohort had a follow-up viral load after starting. So they didn't have data on all of these patients after in terms of viral loads. And so these are the outcomes. So looking at, the green being those that had baseline viral loads over 50 and the yellow viral loads over 200. Having a last viral load of less than 50 was, 75%, and a last viral load of less than 200 was 90 to 95%. And they identified 4% that had confirmed virologic failure in that, relatively short follow-up period. And so, based on that data, I'm just going to kind of go through what we put together as our strategy on how to approach patients. And again, this is really focusing on how can we achieve and maintain viral suppression using injectables in people who are unable to be adherent to oral ART. And so, kind of looking at what we identified as what would be patients that would be, candidates for our strategy, which is really, what we're talking about is giving a dose of lenacapavir with cabotegravir initially, and then continuing cabotegravir, and we'll go through the dosing strategy. But what we're looking at for patients are, people who are obviously expressing interest in using long-acting injectables to support their adherence. Patients who, who really just persistently over time have shown an inability to achieve suppression on oral ART due to adherence. And generally we're going to reserve this strategy if they have viral loads of greater than 200 copies, and we'll talk about some nuances to that in a second. But also, trying to generally reserve this when patients have evidence of, disease progression secondary to not being able to achieve suppression and having, decreasing CD4 cell counts and really needing an intervention to get them suppressed. Obviously, active absence of hepatitis B infection, defined as having a negative hepatitis B surface antigen. Um, and again, what we're talking about is people who have susceptibility to both cabotegravir and rilpivirine, determined either by their treatment history or prior resistance testing. And kind of lastly, trying to look at their ability to attend prior clinic appointments. At least at some reasonable interval that we think that they're going to be able to get their injections on time. And again, there's always flexibility in all of this, if we're going to, take this approach, we want to, at least believe that they're going to be able to adhere to the injection schedules. And so just some thoughts around, coming up with patient selection criteria. I think it's important to keep in mind that, this is off-label use, combining lenacapavir with cab and rilpivirine. And, there is obviously costs associated with, one, not just the medications, as it's, the combination's quite expensive. But also, resources, right? There's a lot of logistics and staff resources needed to do, to do injectables in general. But also, so given those things, the preference is really to reserve using lenacapavir in those that have really shown that despite multiple interventions and attempts, they're just not able to adhere to oral ART, and achieve suppression for at least 2 to 3 months. Because if you can get them to, at least for a very short term, take their orals, get suppressed. Then you can just take the latitude study approach, which is then just switch to cabrolpivirine. But when we think about that, I think it's important to think about not just like an isolated viral load of less than 200, but their duration of suppression when deciding what approach to take. And I think we were kind of informed by that just from our, experience where we had a couple patients who, had a, more quite advanced disease, and long-term history of not being able to take their oral meds. They actually were able to get suppressed on a very short-term basis, but it was, less than a couple months. It was really, kind of a one-time viral load that was less than 200, and we tried, or this was going, early kind of cabrolpivirine, switching them quickly to cabrolpivirine to maintain suppression, and we had a couple patients with failure in that situation. And so I wouldn't just take that single viral load as being suppressed and quick switch, but I would say at least a couple months of suppression would be more ideal. Um, and again, this isn't intended for people with underlying rilpivirine resistance because if they're viremic and they have rilpivirine resistance, that's kind of a different scenario. And that's kind of an individualized approach in that situation on different strategies, and we've approached that as well, but with different medications as well. The other thing I think that's important to kind of think about is, we talk about how, ideally we want to, do this in people who are showing, evidence of disease progression, obviously. But, that's also flexible. It's not saying we have to wait until their T cells are less than 200 or anything like that. There's also the consideration of transmission risk as well in people who are, continually having detectable viral loads. So obviously there's flexibility around all of this. In terms of, kind of the treatment strategy, so, day one, the patients are getting the first day of the oral lead-in of lenacapavir, so two 300 milligram tablets taken by mouth. They also get the subcutaneous lenacapavir injection of 927 milligrams. And then intramuscular cabotegravir 600 and rilpivirine 900 injections on day one. On day two, they need to take their second dose of the oral lenacapavir lead-in. And then 1 month later, they'll get their next dose of cabotegravir 600, 900, and then every 2 months after that, with the known plus or minus 7 day dosing window for cabotegravir. And so The strategy then is that generally lenacapavir we end up discontinuing after the first injection, as long as they achieve an undetectable viral load by 3 months, viral load of less than 50, generally. And if that's the case, then they're essentially, then maintaining another 3 months of suppression after that, and can be managed with just cabotegravir rilpivirine going forward. If they have detectable viral loads beyond 3 months, then we consider giving a second dose of subcutaneous lenacapavir 26 weeks, plus or minus 2 weeks after the initial lenacapavir injection, so every 6 months. So just some thoughts around, kind of this treatment strategy. When we think about using two drug regimens in people who, are either treatment naive or have detectable viral loads, always, those regimens are going to include at least one of the agents with a high genetic barrier to resistance, usually dolutegravir or darunavir. There's, obviously data around using two drug regimens with darunavir as well. And because otherwise, two drug regimens are really reserved for maintenance of suppression, particularly cabrylpivirine, obviously. And when we think about the genetic barrier to resistance of, cab, rilpivirine, and lenacapavir, for cabotegravir, it's not as well characterized, and it is obviously referred to as a second generation integrase inhibitor. But we know, based on the studies and real world that if someone does fail a regimen, a cabotegravir rilpivirine regimen, integrase resistance it does emerge in a proportion of patients and in a greater proportion than what we would typically observe with the oral second gen integrases and integrase-based regimens with, bictegravir and dolutegravir. And so I think that, I wouldn't characterize it as being as having as high of a genetic barrier to resistance as the oral second gen instis like dolutegravir and bictegravir. We know that rilpivirine also has a low genetic barrier to resistance. And then, with lenacapavir, it's also not very well defined, what is its barrier to resistance. But, I think just, looking at the studies, we know resistance to lenacapavir can develop if it's not used with another fully active agent, which is true for a lot of antiretrovirals, obviously, but we do see lenacapavir resistance. Anecdotally, we've had a patient where Len wasn't combined with a high genetic barrier drug, and that two drug combination didn't hold up either. And so, I think again, it's not something that we can say high or low barrier, but we know that lenacapavir resistance does happen in certain scenarios. And so the other thing to consider is, that if the data that's available with real-world cabrylpivirine alone in people who are viremic, they use mixed dosing strategies. Some are giving every 4 weeks, some are giving every 8 weeks. And in general, response rates are going to be lower than what we observe in people who are already virologically suppressed and switch to cabrylpivirine. And so the thought is that by combining, an initial dose of lenacapavir with the cabrylpivirine, that might provide advantages over giving just cabrylpivirine alone. We know that, when we treat people who have, lower CD4 counts and more advanced disease with high baseline viral loads, any regimen is at a greater risk of failure in that situation. So, I think, using a three drug, fully active three drugs does make sense in that situation. The long dosing interval of lenacapavir is obviously very advantageous. So you're getting, 6 months of a fully active drug. Um, and we know that, there's well-established success of using three drug regimens in people who are either, initiating or restarting ART that have detectable viral loads. And so the thought is potentially using three fully active agents instead of two can reduce the risk of viral breakthrough. We don't have direct evidence of this, however, right? This isn't a studied regimen option or combination. We just have some of our anecdotal information, which is, obviously still quite limited. But I think it's important that we consider that this is a population of patients who already has demonstrated a lot of difficulty with adherence to oral medication. And our goal, really is 100% success. It's the last thing we want is someone to lose their injectable options when they've already proven they can't take oral meds. And so, I think that lends to the goal of using, a regimen that's going to give them the greatest chance of success. And potentially, with the idea that, some are using Q4 and some are using Q8 week injections, using lenacapavir for that initial at that initial dose, might allow, us to more consistently use Q2 month dosing instead of Q4 week, which is, convenient obviously for the patient so that they don't have to come in as often for their injections, which might lead to better success as well. And then, as I mentioned, if viral suppression is achieved at 3 months, we should be able to just maintain suppression with cabrolpivirine alone, because we know that there's great success with using cabrolpivirine in people who are already suppressed. In terms of suggestions for monitoring patients, so monitoring the viral load monthly for the first 3 months or until they become undetectable. Um, Also, obviously, monitoring CD4 counts. For appointment adherence, all of our patients, including those that are on, len plus cab plus rilpivirine, are monitored for injection appointment adherence using our kind of well-established clinic practice for monitoring everybody receiving injectable ART. So when they show their injection appointments, they start getting daily outreach via phone, text messaging, or MyChart messaging. And if the patient's going to fall outside of the recommended cabrolpivirine dosing window, there should be an attempt to oral bridge with oral ART until they come in for their injections. Obviously, that's going to be a challenge, and a population of patients who already are proven they struggle with taking oral meds. Um, and then just a note, regarding hepatitis B, those that have a positive, obviously we're not, we're generally not going to use this strategy in people who have, active Hep B with positive surface antigen. They really need anti-hepatitis B treatment. But those with positive core Hep B antibodies could be at risk for reactivation, particularly as they become more immunosuppressed. However, just keep in mind they're probably already not taking oral ART, so it's not an issue of stopping, active Hep B and having a flare, but still recommended to monitor their transaminases. I think there's some important patient counseling points if we're going to pursue this strategy in patients. One is obviously having a detailed discussion either with their provider or one of the pharmacists about the different methods of delivery and the dosing intervals of the different LAI agents, obviously the potential side effects of the medications, and then also the importance of adhering to their injection appointments. I think it's important that patients understand that this is off-label use of this combination, and there isn't clinical trial data to really support this strategy. And so, we're not able to accurately say, you have X% chance of success. But obviously, we expect, that, based off of what we know, that we should see good success with this combination. But they should know that this is off-label use. And then I think it's really important to stress, given the long-acting nature of these medications, if they choose to discontinue injectables, there's this obvious, long period of the pharmacokinetic tail as these medication levels drop over time, and there's a risk of resistance happening during that period if they're not going to maintain suppression with oral medications. And again, we're talking about patients who struggle with adherence to orals. And so, we've seen some resistance occur during the PK tail, both with lenacapavir and with rilpivirine. And so I think we need to stress that to patients if they're going to, move towards injectables. And then the other piece of this is the potential risk for immune reconstitution inflammatory syndrome in people who have, really low CD4 counts. And, they haven't been suppressed for a long time. They've had low CD4s for a long time. And then we give them an effective injectable regimen. There's this potential for iris, and we've had a couple unfortunate cases around that. But It's important to rule out, any concern for opportunistic infections first, specifically, cryptococcal meningitis and tuberculosis before starting these injectables. So, in terms of what we've seen with our experience so far, it's a small group of patients. We've actually, used this strategy now in 15 patients, but two have been quite recent. And so, 13 have had at least a year of follow-up time. Their median age was 43. Majority were non-white, roughly 50% Hispanic ethnicity. All were male, sex assigned at birth. Our mean baseline viral load was about 33,000, and 6 out of the 13 had a baseline viral load of greater than 10,000 copies. Median CD4 count was 123, 8 out of the 13, so 61% had a CD4 count of less than 200. And majority did have at least some, prior drug resistance, about two-thirds with NRTI resistance, about a third with NNRTI resistance, although not rilpivirine resistance. So majority of that was K103Ns to efavirenz. One patient had an INSTI mutation that didn't affect cabotegravir, and one patient with protease inhibitor resistance. So majority did have, viral loads over 200, although there were 5 patients out of the 13 that did have a viral load of less than 200 when we started the injectables. Again, all of those had viral loads of less than 200 for a short period of time, so less than 2 months, range of 13 to 59 days. And so hence why, lenacapavir was still decided to be included. Um, so in terms of, outcomes, we had 2 patients out of the 13 lost to follow-up, unfortunately. One received their first set of injections with len and cabotegravir and then disappeared for a year. He resurfaced a year later, and amazingly, his CD4 count was 306 from a baseline of 4. And his viral load was not suppressed but lower at 1,840 copies a year later. Um, we actually were able to look for lenacapavir resistance, which he did have, unfortunately, but no cabotegravir rilpivirine resistance. And he was then unfortunately lost again after getting those labs done. A second patient was lost to follow-up after his second cabotegravir injection. He came back to clinic 6 months after that second injection, and was still undetectable from a baseline viral load of 19,900. He was restarted on oral meds. He wasn't ready to further commit to injectables, but since that time, he's also not come back to clinic for repeat labs. We did have 2 patients out of the 13 also unfortunately pass away. One was due to an unknown cause 5 months after starting the injectables. He did achieve suppression after 43 days from a baseline viral load of around 50,000 and a baseline CD4 count of 25. It was suspected possible overdose, as he had known substance use. The other patient passed away likely due to iris secondary to known MAC infection at 4 months after starting injectables. He also had achieved suppression after 29 days from a baseline viral load of 50,000, and his baseline CD4 count was 2. So that leaves 9 of the 13 that had continued treatment through at least 12 months. Of those 9, all of them had viral loads of less than 200 at week 48. We had 2 patients who had a viral load between 50 and 200. The rest were all less than 50. Both of those were attributed to having some persistent low-level viremia, and they're not considered virologic failures. Um, Median time to viral suppression in those that had viral loads of greater than 50 was 60 days. And we did have one additional patient after who reached the 1 year mark, but after had to switch back to orals because of a drug interaction between his cabotegravir and chemotherapy after a recent cancer diagnosis. But he's actually doing well so far on oral medication, which is good. So limited data, not that many patients, but at least to this point, we haven't seen any virologic failures. And so, going back to that original patient case of AT, so he did start lenacapavir with cabrolpivirine March 23rd, 2023. He got his second cabrolpivirine injection May 1st, 2023, so he's already late for his second injection. But then every 2 months after, and we did stop the lenacapavir after the initial injection. He did well for the first year. He received all of his injections on time through February of 2024, but then was lost to follow-up for 5 months, which would put him, 3 months late for his injection, and resurfaced at the clinic in July of 2024. He reported, missing his injections because he got stuck in Palm Springs due to his car breaking down. We got a hold of him once while he was in Palm Springs, and we tried to get him back on taking orals potentially. He did pick up a prescription for BF-TAF at the pharmacy out there, but I doubt he really took any of it. He said he took some of it. Um, so at that visit in July, we decided to get labs and restart cabrolpivirine injections with the next injection 1 month later because he would have to do the reloading. We also drew an archive genotype at that appointment because we weren't sure, one, what his viral load would be, and two, there's always this question about, during the PK tail, drug pressure and the impact of that drug pressure or lack thereof on, RNA genotypes. And so, but the archive genotype did come back with, again, only an M184V. So, that was already known that he had that, and he was still undetectable despite being 3 months late. So this is his viral load trend. This is March of 2023 when he started injectables. He, suppressed at about a month, a little more, and then, has maintained suppression through even when he was late for his injections. And then he had good CD4 response as well. So CD4 is increased to around 400. So again, the intention was for him to come back in a month, get his next injection, but he was once again lost to follow up for 4 months. So again, 3 months late for his injection. He did eventually, we got a hold of him and he came to clinic. This time he didn't really identify a specific reason for not coming on time, although he did mention difficulty paying for parking. So we did try and or we gave him all the information about how to use his insurance for transportation instead of having to pay for parking. But he didn't take any oral bridge during that period. So again, we decided to get labs and give him again another chance and use cabrolpivirine with a reloading in a month later. The labs, this is from November of 2024, so he was still suppressed. And he's done well since then. So now for over the last year, he hasn't been late for a single injection and has maintained suppression. So I think this is, a scenario of an example of, this is a patient who this is a really beneficial strategy for, and so far, good outcomes for him. So like I had said, this is, we're talking about using this strategy in people, with fully susceptible, susceptibility to cabrolpivirine and non-adherence to oral ART. There are other considerations for using fully injectable regimens with lenacapavir that, we've been doing as well. Some of these scenarios might include, people who do have rilpivirine resistance, and they are receiving, lenacapavir plus cabotegravir with or without rilpivirine. There's definitely other clinics using len and cab alone together. And this includes even a couple patients who failed cabrolpivirine but only had rilpivirine resistance, and so they've maintained suppression on lenacapavir plus cabotegravir. Um, we have, patients with some INSTI mutations that have some unknown impact on cabotegravir, so use the addition of lenacapavir. Patients with resistance mutations and persistent viremia. In that scenario, I don't feel overly comfortable using, a regimen of just len and cab with activity when someone has detectable viral loads. A couple times we've used ibalizumab in that scenario. Patients who have persistent viremia on cabrolpivirine but without resistance, we've used lenacapavir, and then we had a patient who developed lipoatrophy at the injection site from rilpivirine. That's a different subject, but wanted to remain on injectables, and so we used lenacapavir in that situation. And then I did just want to touch on, this risk of iris. We did have this unfortunate case of a patient. This is not with len and cabropivirine because this patient had rilpivirine resistance, but this was using fully injectable regimen in someone who was not suppressed and had advanced disease. He was a 51-year-old with long-standing non-adherence to antiretrovirals. And we had tried we tried very hard over the years to help support him. Weekly appointments, weekly pillbox fills, daily phone calls, but without much success. And, he has, again, methamphetamine use disorder, depression. And so, he had been on ART, on and off, ART mostly off since 2000. He had been on various salvage regimens with enfuvirtide, Maraviroc. Most recently, he had been on darunavir, FTC TAF, plus dolutegravir since 2019, but not taking it. And he did have resistance. So, from a resistance test in 2007, he had known tenofovir resistance with the K65R, also rilpivirine resistance with L100I. And these are his viral loads since 2019. Not able to achieve suppression. Viral load was 210,000, and his CD4 count was declining and was 10 prior to starting. So, he expressed interest in trying injectables to get suppressed. We ended up using ibalizumab every 2 weeks IV with subcutaneous lenacapavir and just cabotegravir intramuscular because of the rilpivirine resistance. He had started that in March of 2023 with a second dose of his IM cab a month later. Unfortunately, about a month after starting, he presented to the hospital with worsening right facial and upper extremity paresthesias, gait imbalance with falls, and worsening vision. And an MRI of the brain at the time showed multifocal asymmetric lesions with significant subcortical involvement, concerning for a demyelinating process with suspicion for PML. And his CSF JC virus came back positive. And unfortunately, his symptoms just quickly progressed and continued to worsen. He, declined further intervention and entered hospice and passed away in May of 2023. And so it's just caution to talk about these risks with patients when they have advanced disease and we're using injectables. I think we all, have these patients who, despite non-adherence, I'm not going to call it homeostasis, but they just seem to kind of keep going with, detectable viral loads and very low CD4s, and maybe they get an OI sometimes, but we all know eventually what the outcome is going to be in patients with that situation and the need for intervention. But you look at this case, and it unfortunately may have accelerated things for this patient. And so in the last couple minutes, because I definitely want to leave time for questions, I just wanted to touch on, what is potentially coming for people that struggle with adherence, focusing on injectables, but there's also, non-injectable options that are alternatives to daily oral ART. And so, we're moving towards having once weekly oral options. And I think the question is, how will that play in people who can't take daily? And can we come up with interventions to support weekly adherence? So one of the combinations closer is islatravir, lenacapavir, oral once a week. And this is, data from the phase 2 study that showed, high suppression rates in people who were already suppressed, right? There's a switch. I don't think we're going to necessarily have data on this combination, though, in people who are naive or have detectable viral loads. So that there's still going to be questions about how we approach people who are detectable with weekly dosing. There's also ulonivirine, which is a novel NNRTI, and it maintains activity against the common NNRTI mutations and has a half-life of about 70 hours, and is also being looked at being dosed once a week in combination with islatravir. And so there was a phase 2b study, looking at the combination of ulonivirine with islatravir in people who were already suppressed and maintained high rates of suppression. Um, And this combination also is going to be studied in treatment naive people as well. And so we may have some data at least in that population. And just to note that this combination, this phase 2b study was with the higher dose of islatravir that was causing decreases in CD4 counts, but is being pursued now at the lower dose of islatravir weekly that does not have the same effect on CD4 counts. And then there's also a novel once a week combination of integrase with a once a week Len prodrug that's in investigation as well as a once a week combination. But again, not clear if we're going to have data in people who are detectable. Other potential long-acting strategies that are coming. This is ultra long-acting cabotegravir with extended dosing interval beyond every 2 months, so dosed at least every 4 months or maybe potentially longer. But um, um, you know that will potentially play into injectable options that are longer than an every 2 month interval. There are several broadly neutralizing antibody combinations also in the pipeline. So N6LS is a broadly neutralizing CD4 binding site antibody that can be given IV every 4 months. The sub-Q isn't being pursued because of some injection site reactions, but this is the Embrace study where they combined it with monthly cabotegravir, again, in people who were already suppressed and also had proven sensitivity to the antibody with good rates of maintaining suppression. They're looking at an IV formulation with this of every 6 month dosing. But again, still unclear about how we might use these in people who are detectable. And then lastly, BNAbs, teropavimab and zinlarivimab, which are broadly neutralizing antibodies against the HIV envelope, dosed every 6 months. And we have a phase 2 study in combining that with lenacapavir. Um, Again, people are suppressed, and it's a suppressed switch study, and they also had susceptibility to both BNAbs, and so also with high rates of maintaining suppression. So I think, there's more options coming for injectables, but how that plays in people who are not on oral ART is kind of yet to be seen. I think we're going to have to continue to be creative in how we approach this. There'll probably be, the importance of real world data too. But I think there's promise with these injectable regimens and people who really really do struggle with adherence. And so I'll stop there. Take any questions. I just want to say thank you to my colleagues in industry who shared some of these slides for the upcoming pipeline regimens as well. But yeah, I'll stop there and happy to take any questions.
Great. Thanks, Lucas. So I know Jill has a question first. Jill, are you there?
Yeah, Lucas, thank you so much. This was great and so helpful to see all the work that you're doing, and it's I'd say truly pioneering. I just had a question for the patients who have the real pivarine resistance, and you decide to continue lenacapavir. Just logistically, are you taking cabotegravir as Apretude, or are you taking the cabotegravir from the Cabenuva, discarding the rilpivirine? Like, how do you do that? Because I didn't know if it was easy to acquire cabotegravir alone for treatment.
Yeah, it depends on the insurance. But I'm not a fan of using Cabenuva and throwing out the ropivirine.
Sure.
There's reasons, mostly insurance reasons, right? You're billing insurance or something and not using it. But
Right.
so if we've done it, we've only used Apretude as the cabotegravir.
And that doesn't get confusing with insurance saying,
Well,
isn't
it's
this for
always
PrEP?
it's always been in the Medi-Cal world and Medi-Cal, it doesn't matter. We can,
Okay.
they cover it. I will note I'm making a pitch to the ADAP committee next week about covering cabotegravir alone for treatment as well, because they only cover it for, obviously for PrEP,
Okay.
but for this situation. But I know other clinics are, using cab and throwing out the rilpivirine. So, you do
Got
what you
it.
got to do, obviously, for the patient, but we've been just using Apretude.
Okay. Thank you.
Yeah.
Great. Tim?
Just to say, thank you, Lucas. And we have a few trials I think upcoming that are kind of relevant. There's an ACTG trial that's looking at lenacapavir and cabotegravir for people who are viremic. It's quite small, single arm study, so that could be an option for similar patients that come up in the future. And then we were approached by V for something called the Quattro study. It's taking those that are suppressed, but it's going to look at the 4-month dosing of cabotegravir and rilpivirine. Unfortunately, I was kind of hoping they would allow people that were already on cab rilpivirine onto the study because that would be, I know we have tons of those that would benefit from perhaps moving to every 4 months. And then lastly, we're trying to I believe it's a naive study from Merck that we're trying to um, get on board with. That's a weekly dose of the NNRTI and islatravir that Lucas mentioned. I think compared to BF-TAF. Um, so yeah, that'll be interesting. And I would say like I have not seen much work around how to support adherence of weekly dosing. Um, so I do think that that might be an area for our colleagues in GPH or Owen to think about, or if there's any kind of formative work about how one might design adherence support programs in that setting.
Yeah, thank you.
All right. Before we get to Shannon, just wanted to touch on Nettie's comment. I don't know if Lucas, if you can see in the chat pod, but she said very helpful, relevant talk. Thank you. I've had a handful of salvage patients that have been using cabergoline alone, but it had one last summer, had a baseline viral load in the 100,000s, and viral load collected on that day came back 1.5 million. She was scared. But he actually had a robust response. 1 month viral load was 548. CD4 went from 60 to 600. But he is someone that she would have added Len if she had heard this talk. So I think obviously this is quite, I think, relevant. Sanjay asked a question. Does Owen try to get secondary contact info for all of these patients?
Yeah, Sanjay, it's a good question. If we can't reach them, we go to the emergency contact, that's listed in their chart and start reaching out to them. Obviously, just letting them know we're, calling from the doctor's office and trying to get a hold of them. It's actually had some success. I find when the emergency contact is the mom, sometimes we get a good response. Otherwise, it's not always fruitful. But yeah.
All right. Shannon?
That's great. Moms get it done. Um, we do. Um, Great talk, Lucas. Thank you. I just wanted to put in a plug for, you brought up the fact that like, yes, we don't have a lot of data to support one way or the other that, the third drug is necessarily needed. But, the flip side of that is just to point out that the vast majority of our data in viremic patients is with three drugs, right? All of our highly active antiviral regimens for the most part have been three drug. And, even with, I'm just looking at like, guidelines talk about it even in the context of treatment failure, to try to use, at least two fully active drugs if one is a high barrier. If not, then really three fully active should be pursued if at all costs. But, even when you look at the two drug data in viremic patients with, a high barrier like darunavir, with INSTI, there was a trend towards higher virologic failure, and particularly with people with RNAs greater than 100,000. So, and even just looking at the data with rilpivirine specifically, we know that there's higher rates of virologic failure with a baseline viral load over 100,000. And so I think that your strategy of adding the third drug, while, there's quote unquote not data to say that it's needed, there's also not data to say that two is enough for the vast majority. I mean, the only scenario really is with really robust RCT data is with Dovato. I don't think it's a coincidence that our most nearest oral option, Juluca, was never pursued as a naive drug, right? Probably for that reason, because of the rilpivirine failures with higher viral loads. They really just pursued it as switch. So I think it's the most conservative approach. The only downside is, the folks that obviously, risk of additional side effects with more drugs that you add. But the differences in half-lives of the drugs and, the folks that are lost to follow-up, where Len is just in their system for so much longer, we lose an additional drug class potentially. But I think that you guys have done a good job of kind of weighing the risks and benefits in these scenarios and selecting the right population where really you got to do what you got to do to get them suppressed. So anyway, great job. But just wanted to point out we don't have a lot of data to say that two is enough, really, because the standard has been three drugs since the mid 90s, right? So yeah,
Yeah, no, I
thanks
think
very
those are
much.
all great points, Shannon. I kind of lean towards the same direction as you. And I think, even in like, for example, that patient that got one injection and was lost to follow-up, a year later, his CD4 went from 4 to 309. And so, yes, he did develop Len resistance, and that's very unfortunate, but there was also some potential, there's obviously some benefit to that. And so,
Yeah, totally.
but yeah, for sure. Well, thank you, everyone. I appreciate your attention.
All right. There's one last few comments from Sarah. It'd be really nice to collate these different approaches and results to elucidate the de facto value add of lenacapavir, was a comment. And I know it's 9:01. Nettie, do you have one last very quick
I actually
comment?
just had an honoring this process point, which is that these are often patients that we've known for a long time and really care about. And we're watching them, sort of go to an inevitable, really bad outcome. So I just want to honor that part of the conversation because we're looking at the data, but often you just feel up against the wall with these folks. So this is really, really important work and important information for us because this has been a data-free zone and we've had to really struggle with people that we've had in clinic for 10 years that we care about, that we're watching them, be lost. So really, really appreciate this. And I think that with all the caveats, it's still really important to say that, we're having some information and data come forward for us to help these folks. So I really appreciate it.
Great. And I see there one last plea from Lisa Silvestro. Can we contact you with questions with complicated patients?
Always, yes.
Lucas,
Always, yeah, yeah.
do you want to put your email in the chat for Lisa?
All right, there you go.
Perfect. All right, we'll go ahead and end for today. But thanks everyone for all the questions and participation. Certainly, thanks Lucas for a wonderful job. I think this is a very pertinent question, and like Nettie said, it's certainly data-free zone. But hopefully, you're going to be presenting some of this at CROI, maybe.
Not this
Not
year,
this one. Okay.
but as we continue to accumulate outcomes, hopefully soon.
Okay, perfect. And Paloma, the code is 17546. All right. Thanks, everyone. Take care.
Thanks.